So because these values were all very low, we began administering blood products pretty quickly to try and correct these levels. His prothrombin time was also elevated, which put him at risk for greater bleeding because he was unable to clot as quickly as his body should normally. We followed the protocols to ensure that the correct blood products were given to the correct patient, and we monitored him very closely for reaction to these products, and we're sure to give them within 30 minutes of when they were received, and we monitored his vital signs, especially his temperature, and as we gave these products to see if there would be any change. And he accepted these products very well with us and had no reactions to them. And these did help improve his blood pressure a little bit, but his red blood cells levels, his hemoglobin, his platelet, and his hematocrit were still low as he continued to lose blood even until the next day. When we look at perfusion and oxygenation, Mr. J's loss of blood made it very difficult for him to perfuse adequately to the rest of his body. And this made his capillary refill very poor. His hands were cold to touch, his blood pressure was very low, and his body's main priority was to keep his essential organs perfused, and that left other parts of the body not as important to be perfused to. And this is just the body's efforts to salvage the more important parts. So we did administer fluids, vasopressors, and blood products, as we mentioned before, with the hopes that this would help him perfuse blood and oxygen throughout the entirety of his body. An important piece with oxygenation with this patient is that he had to be ventilated through his trach tube continuously in order to maintain an O2 saturation that was appropriate. And so that was something that we had to be mindful of and make sure that the oxygen was placed securely on his trach tube. At one point it had become a little bit dislodged or moved, and his oxygen sats dropped very early into the 80s, and we weren't sure why until we noticed that it was placed incorrectly. And so these were things that as the nurse we had to be very mindful of and pay attention to. When we look at mobility and alignment, Mr. J was not able to control his own body due to his brain injury in January, so we had to position and reposition him as was necessary. And this lack of mobility places him at great risk for developing infection, developing pressure ulcers, and even blood clots. And during my time with Mr. J in the emergency department, we did not put as much emphasis on the area of mobility and alignment, but as you look at the care that he would require after leaving the emergency department, it's very, very important that nurses would do passive and active range of motion with him, and that they would also reposition him every 2 hours. So moving on to pain. Pain was very hard to gauge with our patient because he was unresponsive and unable to verbally communicate. So we had to depend a lot on his facial expressions and some of his body language and restlessness and things of that nature. And on different occasions, his body did communicate that he was probably in a great deal of pain, as his face would grimace and his arms would be very restless and seem to be grabbing onto something. So to help him deal with his pain, the doctor ordered morphine, and we administered this as necessary, and we also administered sedative medications to keep him comfortable as we cared for him. The moment where he seemed to be in most pain was when he arrived to the emergency department and his abdomen was very, very distended. Um, he had that face grimace and that restlessness in his arms. And once the urologist removed the catheter and his bladder was able to drain out all of the blood that was inside, he felt much more comfortable, and you could tell that his body language was relaxed and his posture was more relaxed, and this really seemed to ease his pain. Some procedures that we performed with Mr. J were administration of blood products, and with this we got verification with the people from the blood bank and also with another nurse to ensure that it was the right patient and the right type of blood. We also made sure that we administered the blood within the 30-minute window of time, and we remained with the patient for the first 15 minutes at least of the blood administration to ensure that there was no reaction to the products, and we kept a close monitor on his vital signs. We primed the tubing with, or the Y tubing with normal saline, and then with the blood. And we're sure to follow the protocol for blood administration as pertains to Moses Cone. Another procedure that was done by the urologist was removing the size 28 Foley catheter and administering and inserting one that was more appropriate, and then started by the urologist and continued by the nurses was the continuous bladder irrigation process that carried on even until the next day of his care. We look at growth and development. Mr. J was in the generativity versus stagnation period according to Erickson, and this was harder for us to assess because he was very unresponsive, immobile, unable to verbally communicate with us, and so this is an area that would take a little bit more extensive assessment to really address. We collaborated a lot with different healthcare professionals, including the doctor who was first to step into the emergency room with the nurses and assess the situation and begin determining what needed to be done and what medication should be given. Us as nurses and nursing students, the respiratory therapist was also involved as we dealt with the trach tube and ventilation for Mr. J. Urologist was also involved with the Foley catheter problems and trying to address that issue appropriately. We also had assistance from CNAs and emergency department techs as we needed different supplies or just needed help moving the patient or transporting him. And there was also a lot of communication between the health facility that our patient came from to the emergency department, and then even as we transported him to another floor where he would be admitted at Moses Cone, there was communication between the different units to continue his care. As we look at nutrition, our focus in the emergency department was really to stabilize Mr. J and get him to a state where he could then be admitted to a unit that he would stay in longer term. And because of this, there wasn't much focus on Mr. J's nutrition. He was NPO because of his brain injury, and he received feeding through his PEG tube, and this would be something where we would need some assistance from the dietitian to assess what would be the best way to provide nutrition for Mr. J. And as he was admitted to the med-surg unit, this was addressed a little bit more heavily. But proper nutrition is very important for him, as this would help his body fight the infection and also recover after losing so much blood, and provide the protein and the energy that his body needs to help him recover. So after Mr. J spent time with us in the emergency department unit, we were able to transport him to a med-surg floor where he would receive the rest of his care during his time in Cone Hospital, and the outcome of his case I'm not sure of, but that was my experience with him in the emergency department.